All right, in this explainer, we are taking a deep dive into Campylobacter fetus, and let me tell you, this is a fascinating pathogen that really breaks all the typical rules for its genus. Just so you know, all the data we're about to cover comes from a comprehensive Gemini deep search, and you can find all the primary sources right in the linked notebook.
So here's our game plan. We're going to start at the bench, figuring out what makes this organism so unique and how to actually find it in the lab. Then we'll shift over to the bedside to really understand its clinical impact, the huge challenges in treating it, and finally, how we can prevent it.
So, first things first, let's really pin down why Campylobacter fetus is absolutely not your typical Campylobacter. When you hear Campylobacter, your brain probably jumps straight to jejuni and, a bad case of food poisoning from some undercooked chicken. But Campylobacter fetus, it's a completely different beast. It trades that localized gut infection for a systemic invasive disease. And its reservoirs aren't poultry, we're talking cattle and sheep. This thing isn't just a gut bug, it's a full-blown blood-borne invader. So what's its secret weapon, right? How does it pull off this systemic heist, surviving in a place like the bloodstream where most bacteria would be wiped out in minutes?
Well, the answer is this incredible piece of biological armor, the S layer. Think of it as a protein shield, an invisibility cloak that makes the bacterium nearly invisible to the complement system. It blocks those eat-me signals, preventing opsonophagocytosis and allowing it to just cruise through the bloodstream. This S layer is, without a doubt, the cornerstone of its ability to cause disease.
Okay, let's head over to the lab and talk about how we actually identify this very challenging pathogen. Under the microscope, it has this classic, almost elegant gull wing look. It's a fantastic initial clue. But, and this is a big but, there's a catch. In older cultures, those beautiful spiral shapes can break down into these little coccoid forms, which can be super misleading if you're not expecting it.
Now, on the culture bench, this organism is pretty fastidious. It needs those specific microaerophilic and capnophilic conditions to grow. And here's a really key differentiator: temperature. Unlike its thermophilic cousin, Campylobacter jejuni, Campylobacter fetus loves 37 degrees Celsius and grows poorly, if at all, at 42. And one more critical point for the lab, some selective agars contain cephalothin, which can actually inhibit this guy, meaning you could get a false negative from a stool culture.
This slide really gets to a major challenge, telling the subspecies apart. We used to rely on biochemical tests, but as you can see, their reliability is, well, it's variable at best. These days, molecular methods are the undisputed gold standard. A PCR for the para-A gene gives you the definitive answer, plain and simple.
So, with its S-layer shield letting it survive in the blood, what does this actually mean for the patient? Let's take a look at the severe clinical syndromes it can trigger. This is a classic opportunist. It doesn't usually go after healthy people. As this chart shows so clearly, it preys on specific vulnerabilities: patients who are immunocompromised, the elderly, and those with underlying conditions like heart or liver disease.
Clinically, it usually presents as bacteremia, but the real hallmark of Campylobacter fetus disease is its affinity for the vascular system. It has this dangerous ability to see damaged endothelium, which can lead to life-threatening infections like mycotic aneurysms and endocarditis. And on top of that, it can cause devastating focal infections like meningitis in newborns.
And the stakes here are incredibly high. These infections are severe. We're talking a fatality rate of around 14%. That's why getting the diagnosis right and getting the treatment right is just absolutely critical.
That high fatality rate brings us directly to the biggest challenge for both the lab and the clinician: antimicrobial therapy.
This right here is the heart of the problem. There is what we call a breakpoint void. Without official susceptible, intermediate, or resistant categories from EUCAST or CLSI, a lab can run a test and give you a number, an MIC, but they can't tell you what it means, and that leaves clinicians in a really tough spot. So how do we work around this? We can't just guess. The answer is to use an inference-based strategy. The lab provides that raw MIC value, and then we have to do our homework. We consult the published evidence, things like epidemiological cutoff values and MIC distributions, to figure out if our isolate is wild type or if it's picked up resistance.
And this table shows that strategy in action. An MIC is just a number until you put it in context. You can see right away that meropenem and gentamicin have these nice, low, tight MIC ranges, which makes them very reliable choices. Ciprofloxacin, on the other hand, is all over the place. It's completely unreliable for empirical therapy.
So based on that data, it's no surprise that both Dutch and international guidelines, working through inference, arrive at the same conclusion. Carbapenems are your first-line therapy. For really severe disease, you add an aminoglycoside. And you absolutely avoid third-gen cephalosporins and fluoroquinolones empirically. Duration of treatment is also key, at least 2 weeks for bacteremia and 4 to 6 weeks or even longer for those deep endovascular infections.
For kids, the story is pretty much the same. Meropenem is the drug of choice, especially for something as serious as neonatal meningitis, where its excellent penetration into the central nervous system is vital.
And finally, given how tough this is to treat, prevention is obviously paramount. So let's look at how we can stop transmission right at the source. Prevention all comes back to remembering the reservoir, cattle and sheep. In the lab, that means handling it as a biosafety level 2 pathogen. Out in the community, it's about basic food safety for beef and lamb and good hand hygiene after being around those animals. But the single most critical public health message, and it's highlighted here for a reason, is to avoid unpasteurized milk and dairy products, which are a major vehicle for transmission.
This is a really complex pathogen, and our understanding is always evolving. Your experience in the clinic and in the lab is so valuable. Please subscribe for more of these deep dives and share your own best practices or any questions you have down in the comments. We read every single one. Thanks so much for watching.